So we'll get started. Hi everyone, and thank you all for coming today for our October Post-Diagnostic Support group. Big welcome to our guest speaker today. We've got Dr Linda Buchan. She's going to be taking today's session, so welcome Linda.
Thank you.
This session is interactive, so your microphones are muted at the minute, but if you do have anything you'd like to share or ask, if you can see at the bottom, you should be able to see, oh, where is it? Is it there? There's a raise hand function, but I currently can't see it. Sorry. So at the bottom of your screen, there's a few icons that you can click on. The one on the right that says reactions, if ever you have anything you want to share or ask, if you click on the hand on there, raise hand, then the icon will appear on your face and we'll be able to see who wants a question, if that makes sense. So yeah, if anyone has any questions before we start. No, we all okay? I am going to remind you that the session is being recorded, but no names or personal information will be shared following this. Okay, so I'm going to share my screen with you for Linda's presentation. And if everyone can see that. Can we see that?
Yeah.
Yeah, great. Okay, so I'll mute myself and then Linda, if you want to start.
Okay, thank you very much. So welcome everyone. I've no idea who's there and who's not there, which is very strange. I'm aware that some people who know me well are probably there and some new people. So welcome everyone. I hope it's going to be worth your while listening to me. I'll do my best. So I have done a presentation before on stress, and again, assuming that everyone knows what the initials PTSD stand for, which is always a mistake. So it's post-traumatic stress disorder. So post meaning after, traumatic, a traumatic event that is perceived as stressful, and then that horrible word that we don't like, but because it's in the diagnostic criteria, we have the word disorder. And autism. I thought this might be a good one to do, given the sort of time we've had recently, and still every day there seems to be mention of a shortage of something or other, and creating quite a lot of uncertainty, I think, in the world. So I'm hoping that some people get something useful from today. I can't claim credit for the slides because they've been done by a number of people supporting me in terms of psychology. So Maddie, who was here as a work-based learning person, and Chloe, assistant psychologist, and an EV psychology intern. So we've got a very solid team for me to rely on to keep me up to date, doing literature searches and so on, which is great. So we've got some up to the minute research at the end of the presentation. Okay, then next slide, please. So if I was in front of you and the group, I think what I would do now is sort of pause and ask people to think about what is stress, and I'd invite people to talk from the audience. But I suppose just a minute to just have a little think about, what does that word mean, stress? And I think it can be bandied about in a way that isn't necessarily helpful. You know, I'm feeling so stressed. What does it actually mean? And what for each of us is stressful? And I think that is such an individual thing, that to try and lump together what is stress is probably a question that maybe we can debate a bit more later down the line when we're all more interactive. Okay, next slide, please. So it's important that we do understand two types of stress that our bodies and brains experience, one of which is evolutionary, highly significant and highly important, and the other is not helpful. So there's a lot of words on this slide, and I'll try and explain the two different types of stress response. I'm aware as well there will be people in the audience who will know more about the acute and chronic stress response than me. So if there's things you'd like to add later down the line, that's great. So the acute stress response, if you like, is so somebody's actually commented on what stress for them is in the boxes. That's really good. So any dialogue that you want to go on while I'm talking is absolutely brilliant. So acute stress is evolutionarily very significant. So if we go back to, you know, when we were in caves and a lion might be coming near us, we would need to act very, very quickly because it's a threat that we need to respond to. And various hormones are released, such as cortisol and adrenaline, and they enable us to respond very, very quickly to stress. And usually we either run away or we stand our ground and fight. There is also the possibility of freezing, where you become immobilized, which again, for example, for certain snakes, the best thing you can do is to remain still. So this fight or flight response is a really good response. It doesn't last very long, and it doesn't really have an impact on any of our bodily systems. However, if you're experiencing stress chronically, so for an extended period of time on a regular basis, this is damaging to the body. And what actually happens is most of our systems shut down when we're stressed. So if you think if we're in the acute stress response, if we're either going to run or fight, then you want all of the energy to go to arms and legs, for example. So you can either run or punch. It means other systems shut down, such as the digestive system, the immune system, and so on, so that everything goes to the fight and flight response. Now, if that is going on a regular basis, you can see the impact. If your immune system is shutting down, then you're going to get ill. You're going to get headaches, you're going to get infections, illnesses. And if this is going on very dramatically, it can lead to some quite serious health conditions, and including a health condition there of depression and anxiety. So chronic stress is dangerous. Next slide, please. Okay, so this, you know, in medical news today, so, you know, we often, I don't know about you, but often I read, you know, somebody who's got a column in a newspaper or something where they're telling you how to make yourself less stressed. So I'm not telling you this as this is what you need to do to manage stress, but this would be some of the advice. And this is for neurotypical people, if you like. So the first is understanding your body's signals and triggers. Well, fair enough. And you can help prevent situations that cause stress or prepare yourself for it. I'm going to talk a bit later about if you're autistic, where you maybe can't prevent those situations, but perhaps there is some preparation you can do. Then talking to friends and family who can offer you emotional support. Well, for some people that isn't an option, and sometimes family can not be helpful and can actually be a stressor in themselves. We all know about the fact that if you go for a walk, about the release of endorphins, and if you go to the gym and exercise, that's fine. And I think mindfulness has become a big thing at the moment as a way to try and focus on the here and now. And whilst those are useful and they do work, I think it's a bit glib to just pass that out. If you just exercise more and do a bit of mindfulness, you're going to reduce your stress. And then the next one, again, for neurodiverse people where we know that sleep disorder, sometimes for physiological reasons, often for physiological reasons, is not something that you could improve. So again, yes, try and get the recommended 7 hours a night so you can wake up with a clear mind. That's great advice, but I think the reality for a lot of neurodiverse people is that isn't possible. Next slide, please. Okay, let's look at something that was produced by Autism West Midlands, and there's a link at the end to some of their resources. So again, some of these are you know, preaching to the converted are obvious to those of you that are in the group. But let's just think a bit about why would autistic people have higher stress levels? It almost comes with the territory, doesn't it? I think the sensory issues are probably massive. Predictability, structure and routine are really important. And then being put into social situations and having to communicate. They then quote a figure that they don't reference that in as far as I can see, but saying that around 30% of people, of autistic people, have been diagnosed as having anxiety. I suspect that that figure is higher than that, but it doesn't really help getting a diagnosis of anxiety if that doesn't then change anything for you. So they're contrasting that with the general neurotypical population, where they're saying that around 9–10% of the neurotypical population have been diagnosed as having anxiety. I talk a bit about the sensory issues, which I think a lot of neurotypical people would not understand at all how for example, a smell could totally overwhelm somebody in a social situation. It's not necessarily the social situation that's caused the stress, but actually the smell that's in the room rather than the people in it. We know that change, disruption to routine is very stressful. Social situations are stressful. And there's a stress in not being able to trust other people. If you can't tell whether somebody is being a friend or not, and you're either too trusting or you're not trusting at all, that in itself can lead to enormous stress. And I'm aware that lots of people, what I would call ruminate, so they think about and go over and over, how did I manage that social situation? Could I have done that better? What do they think of me? Maybe I should have done this. And so not only the situation itself is stressful, but then ruminating about it, thinking about it, adds more and more stress. And of course, you can get a loss of relationships, which for any of us is extremely stressful. Next slide, please. So let's think about what the National Autistic Society more recently have tried to put out things around the pandemic and so on, and trying to think about stress. Although I know for a lot of autistic people, the pandemic has reduced the stress, and social distancing is brilliant. Not having to shake hands is brilliant. And cutting back on social situations for people has been brilliant. So again, we've got to watch that we don't make these generalizations. But let's have a think about how we can manage stress. So it is important to try and understand your triggers, but I think you often need other people helping you with that. I've noticed every time this happens or that happens, you seem to get very stressed. If you know a situation is going to be stressful, then if you remove yourself from that situation, then of course you're going to reduce the stress. But I think that's often quite difficult for people because I think you almost get an acute stress response sometimes in those situations where you freeze. And although you want to remove yourself from the situation, you can't. Lots of you will have adapted to your sensory overloads by wearing noise cancelling headphones, carrying around fidget toys, etc., etc. and trying to reduce the uncertainty by scheduling your day and planning for possible changes. Now, there are people that have developed other ways of trying to look to see whether they're going to become stressed. So a young woman in Denmark, she plots out her days of the week and she colour codes them. And her colour coding system is green is a day with limited stress, amber is some stress, and then red is this day is going to be enormously stressful. And she therefore looks ahead and thinks, I've got 2 red days that week. I need to make sure that I have a number of green days that follow that. Chloe and I recently had the privilege of speaking to a young man who has developed his own battery, like your phone battery. So when he's on reduced battery, he knows it's going to be stressful. And he's also very cleverly using his friends by showing them his battery so they can see, oh, he's on 50%, we better be a bit careful here, or reminding him that if he's on 50%, he needs to do something about that. So again, I'm sure a lot of you have developed your own ways of trying to manage stressful scenarios. That, of course, isn't always possible. If you're a parent, you can't say, I'm necessarily, I don't think I can manage my children today, although it may be that you can call upon family members or others if you know that you're not in a good place. And a lot of people self-soothe by using sensory things or other objects that bring comfort. And I'm hoping people are not feeling embarrassed about what some of those might be. And sometimes you can carry them around with you, but it's not obvious to other people. And I think that reduces the stress as well. Next slide, please. Okay, so let's get back to what is post-traumatic stress disorder. So the NHS defines it as an anxiety disorder caused by very stressful, frightening, or distressing events. Now, in the Diagnostic Statistical Manual, they're very clear about what constitutes a stressful event, and it's often sort of life-threatening. And some of the examples that the NHS have said are things like car accidents, being sexually assaulted, tragically your child is stillborn, and those are obviously incredibly traumatic. However, I think there are other situations, but because again, all the criteria have been written for neurotypical people, the trauma that might be experienced by an autistic person leading to post-traumatic stress disorder probably would be dismissed. And we're going to talk about that in another slide. Now, what do you, when you get post-traumatic stress disorder, you get nightmares, very vivid nightmares. You can get flashbacks while asleep and whilst awake. And you can also get hallucinations of the actual event. So not just a flashback, but as if you're reliving that via an hallucination. The NHS goes on to say that they may also be feeling guilty, irritable, and find concentrating difficult. Well, I think, you know, that is something that autistic people probably feel more than neurotypical people on a regular basis in any case. Next slide, please. Okay, so there is a term, which again, I know people who are in the audience will be probably more up to date with than I am, but talking about complex post-traumatic stress disorder. So this is where there have been multiple traumatic events, for example, violence, neglect, abuse. And again, sadly, my experience of a lot of autistic people, a lot of autistic women, is that they, because they can be very trusting, because maybe they struggle to understand people's motives, they can end up in relationships which are abusive, and that can continue, that one relationship ends and they believe the next person who comes along is going to be kind and nice and look after them if they need that, and that isn't the case. So the symptoms are described as similar, but as goes with the territory, more complex. So you do get the physical symptoms, you do get the concentration. It can lead to quite destructive behaviours and certainly leads to relationship difficulties. Some people are misdiagnosed because there are parallels with what has been defined as borderline personality disorder. Some professionals are not aware of complex post-traumatic stress disorder. And the NHS say, if you're not comfortable, talk to somebody so you're getting the correct treatment, and recommends the Mind website. I do think Mind are a good organisation by and large. I think it's very difficult to challenge mental health professionals, in my experience. Next slide, please. Okay, so these are, the next two are some current research projects. Some of you may recognise the second name, which is Francesca Happe, who is a brilliant researcher and often researches areas that aren't the ones that the fashionable ones, in inverted commas, the ones that everyone's interested in. And she has been doing quite a lot of, she's been trying to get research grants to look at older adults, not very successful, even though she's a brilliant researcher. So clearly she has managed to get some money to look at post-traumatic stress disorder. And knowing what her remit is, she's coming from a position that autistic people are not being diagnosed properly, and therefore that does not lead to the correct treatment. And I'm using the word treatment here, and I will talk a little bit about intervention for post-trauma. So her research group found that being autistic meant a wider range of life events could be traumatic. So she was sort of blowing open, if you like, the Diagnostic Statistical Manual's definition of what is a traumatic event. It's a small sample, but she did give questionnaires out regarding life events and mental health issues. And she looked at whether they would be considered traumatic by the Diagnostic Statistical Manual or not traumatic. So if they're not deemed traumatic by the Diagnostic Statistical Manual, you don't get the diagnosis of PTSD, and therefore you don't get any intervention. So a large number of those people, 40%, had experienced what sounded like probable PTSD within the last month, and 60% reported trauma at some point in their lives. And this was not what's called a clinic population. So quite often research is done on what are called clinic populations. So those are people that are in touch with mental health services by and large. So this was a group of people that were not in touch with those people. So if you don't get the diagnosis, if people don't perceive those life events as traumatic because they're not in the current diagnostic criteria, you're not going to get help. So I've seen somebody's put, this seems ridiculous, as it is. So, sorry, I'm getting distracted by the brilliant dialogue that's going on between lots of you. So being autistic, in my opinion, and according to this research group, increases the chances of complex post-traumatic stress disorder and post-traumatic stress disorder. I'm going to say what EMDR is in a minute, from somebody who's asked that question. Okay. So, well, now you've asked that question, let's talk about it. So if you get diagnosed with PTSD, the NICE guidelines, so those are the guidelines, and they are just guidelines, but people do seem to take them as rules rather than guidance. There are two interventions that are recommended. The first is what's called trauma-focused cognitive behaviour therapy. And the second is EMDR. And I always forget what the initials stand for. My understanding of it, and when it first came out many years ago, I thought it seemed the most weird placebo laying on of hands type intervention, and I poo-pooed it. However, people I trusted were starting to use it and getting quite dramatic results. We do have thank you. Yeah, everyone's trying to help me out with what it actually stands for. And somebody knows far more about it than I do. So EMDR, my very limited understanding of it is that it allows people to relive the trauma in a very safe way, such that the trauma then reduces. And I think this is probably something where I would really welcome if anyone's had experience of it, and if it's been helpful, and people help me out with the explanations. I do not claim to be an expert on either of those interventions. I haven't been trained in either of them. Okay, next slide, please. So this is another current study. So you can see it's 2020. And these were the key findings. So the autistic people, especially the women, reported more negative life events, and they were particularly around social events than neurotypical people. And of the autistic population, 60% chose a social event as their most distressing event, whereas only 20% of neurotypical adults indicated a social event was their most distressing event. Individuals with autism and PTSD actually had poorer social skills compared to people who had autism. So to me, that implies that the PTSD made life more difficult, more complex. People were maybe withdrawing more into themselves, maybe reducing their socialization. So it would appear there are vulnerabilities in the autistic world to trauma and PTSD. And there appears to be two relevant findings here. Firstly, that social stressors are much more significant than in the neurotypical population. And also women with autism being vulnerable to PTSD, which I don't think will come as a surprise, particularly to many of the women who are in the group at the moment. So what I'd like to do is I do want to, for those of you that used to come to the group when we were at Crewe, what we would do after the, sadly, no cakes from my son and no refreshments, but people can go off and have a break and then come back, or we can have a dialogue and then have a break. But what we often did after the presentations and so on is that either people like myself would give an update as to what was happening in Axia, where we were heading, what we were thinking about. And I would quite like to tell people about an away day we're having on Friday, and also a some issues around our resources, not issues, some pointing in the right direction for our resources. So just giving Dream the heads up here. And also, although we're not out of hours service, we do want to point people to good out of hours services. So again, I'd quite like to update people as to what Axia are doing about that. And also for people to ask us any questions, because one of the things about the group is it wasn't just about imparting research studies and so on. It was also a way of feeling connected with Axia. And clearly that's been difficult over the last little while, but I do want to start getting more of that connection back so that when we discharge you, you don't feel like you're being discharged into a void, that we are still here, albeit, you know, maybe virtually or via the website and so on, but we are still here. So Chloe, Evie, I don't know whether you feel we should open up the discussion now and then have a break. It looks like there's been a lot of chat going on in
Hi.
Hi.
We could go for a break now and then continue, or if we were to continue with the chats now, would you think we would have a break or just finish a bit earlier? What do you think would be best?
I will be guided by the group.
Okay.
So it looks to me like we've got 30 participants. That's enough good. So I'm assuming those people had an expectation about today. I feel somebody's saying they'd rather have a break because they've not had lunch yet.
Yeah, is that a common thought with people? Would we like a bit of a break to get a drink or something? Yeah, I'm getting some nods. So should we
Okay, right.
go with that?
Yeah, and we don't have to extend it to the 2 o'clock.
No, if we have like a 10-minute break or something and then meet back and we can finish discussions and stuff, yeah?
Yeah.
I think we're just after past now, so if we come just after 22?
Yeah, lovely.
That'd be all right with everyone? Yeah? Okay, I'll see you back here in about 10 minutes then, everybody.
Wonderful. Thank you very much.
Okay. So that's been sort of roughly 10 minutes. If everyone's ready to sort of have a look through the comments that were made in the chat and share some of those. Where are we? So I don't know if everyone can see, I'm sort of going through the chat just now. I don't know if everyone can see that on their screen, but if not, we'll just read them out. So that should be okay. So is that okay to do that, Linda, if I just read them out?
Yeah,
and then
lovely, yeah.
Sort of jump in. So someone had commented, stress for me means not feeling validated, not feeling heard, but seen as a diagnosis instead of a human being, if that makes sense.
Sadly, yeah, that does make sense, and that's quite tragic.
Mm-hmm.
So the whole point of the diagnosis is it's meant to open up things, not close down things. So very sad to hear that.
Mm-hmm. Talking about smells, saying smell can be so bad, I feel nauseous, while a neurotypical person might just wrinkle their nose.
Yes.
Smell so hard to avoid.
Yeah, it is. It is. Yeah. I don't know what to say to that. I mean, other than carrying around a smell you do like on a surface that you could maybe cover your nose with, but it's just so hard, especially if it makes you nauseous or even vomit, which I've known people do. And that can happen. That isn't, you know, how Luke always talks about, there's no behavior that is autistic. So we all, you know, there are certain smells that make us all, you know, some smells that make me gag and could make me vomit. So it's not that we can't understand that, it's just people would go, well, I can't smell that at all, what are you going on about? So again, it's this total underestimation of, and, you know, not, even if you don't understand, it's about accepting that that's the person's reality.
Mm-hmm. talking about change, somebody saying they used to walk out of work if there was an unplanned change. I don't anymore, but instead get very annoyed for the rest of the day and bad-tempered.
Yeah, I mean, obviously it's not a good look, is it, walking out of work when it's so I can see in a way progress in inverted commas. So not walking out, which your boss wouldn't be very pleased about. But again, it's so easy to not. It should be relatively easy to warn people that there is going to be change if you do know that's going to happen. So one of the things that happens in our building quite a lot, I'm sure you'd agree, Chloe and Evie, is they're going to test the fire alarms. And it's annoying. I understand why they have to do it. But if we know it's going to happen, you know, we've got noise cancelling headphones in the rooms for children and adults. We can tell people it's not a fire, it's a drill. We can tell people roughly when it's going to happen. And then it becomes more predictable and more easy to manage. And obviously for any workforce, if you can let everyone know there's going to be a change, that's going to be better for all the workforce.
Mm-hmm. Talking about the sort of colour coding, red, amber, green, someone had said colour coding is interesting. I do similar to managed work, but it's never been that explicit. Luckily, I'm allowed to work from home sometimes. I try to schedule that if I know the day before will be stressful. And then somebody had sort of responded to that saying, I do that too, have recently been learning how to try and conserve my energy levels by planning better.
Yeah, I think that's a really good thing to do, to just where you can't stop something happening, but you could maybe make sure that the days around it are much less stressful. I think that is a really good idea.
Mm-hmm. Sorry, I've just jumped down to the bottom. Bear with me, I've lost my space. So talking about sort of tactile stress release, somebody had said I carry sheepskin pieces in my pockets, highly soothing, nobody sees it. Somebody else has a small Rubik's Cube on a key ring on their handbag that is quite a sort of discreet. And
again, I think, you know, lots of people carry around things that are comforting and meaningful to them. The more discreet you can do, the better, because, you know, most autistic people do not want attention drawn towards them. So if you're walking around with your comfort blanket and it's big, unless you can incorporate that into, you know, a shawl or a jacket or turn it into a brooch or something like that. So yeah, I think it's better if it's discreet, because you don't want people asking you lots of questions about it.
Mm-hmm. Talking about DSM-5, someone saying, unfortunately, emotional flashbacks are not in the DSM-5.
Oh, very helpful.
Mm.
Well, as you know, my thoughts on these criteria are, if we got them right, then we wouldn't have to keep revising them. And it's right, okay. So sorry about that. It's the American Psychiatric Association.
Somebody asking, did anyone have memory issues blocking out the memories in relation to the CPTSD? I didn't remember mine until I had my daughter, which triggered the memories.
I do know of people where they had blocked something out, and then something did trigger it, and then they could not stop the thing they had blocked out, which probably was quite an effective strategy. But then, yes, giving birth, I suppose, you know, there's going to be such a massive hormonal change, let alone anything else. But yeah, I have heard of that before, where memories become unblocked and then become incredibly intrusive.
Somebody else and similar, I don't have PTSD, though I seem to have blocked out my whole childhood pretty much.
Again, that's I've been quite surprised by how many people I've met where I've asked them about their childhood and they have absolutely no memory whatsoever. I think that can be a very useful strategy, which is why you've got to be so careful with therapists. So it's not always a good idea to unearth and uncover things that you've buried for a good reason. So it's really important that if you have a therapist and you have an inkling that they don't understand you or trust you, or you don't trust them, I think to terminate that relationship sooner rather than later. So for some people, it's much better that you leave those doors closed if it's not impacting on your life. Yeah. I mean, that's in contrast to a lot of autistic people's memories that are so, you know, we talk about that synchronicity where an event that happened yesterday is as vivid as an event that happened 20 years ago. And that, again, is really difficult to deal with. So those stupid expressions like time's a great healer can be very unhelpful to lots of us. But I think particularly if you've got that synchronicity of memories where they're not sort of categorized past coming up to present, that they're all in the same sort of time frame.
Somebody saying, I've had huge issues challenging the need to hospitalise me if my mental health deteriorated due to hospitals being a huge trigger. They've removed it from my care plan but accused me of not engaging with them due to my insistence on accessing EMDR.
Well, I would tell that person to get the NICE guide, that they've probably done all this, but let's say it in case, the NICE guidelines for post-traumatic stress disorder, and highlight what interventions are recommended. It may be they haven't got anyone who's trained in EMDR, and if that's the case, then you're entitled under patient choice to access that from another clinical commissioning group. I think there's not a lot of skilled practitioners in EMDR. We luckily as I say, I've got two of the psychologists here who are trained in it, and also Kath Norgate is based in our building and she's chair of the EMDR Association. She's based at Red Hill House, and she's an enormous source of knowledge and support. So it's Kath Norgate. She probably won't thank me for publicising that, but she is very, very good, and she's based at Red Hill. So if you need any more ammunition about why EMDR is the intervention of choice for trauma, it's probably on the website. You know, you probably don't have to speak to Kath. It's probably all there.
Somebody saying, this seems ridiculous as it is subjective, and if those individuals felt traumatized, then it should be accepted as trauma. Somebody else, agree, should not be called subjective. One knows what felt traumatic and what not.
Yeah, I think it's a bit like self-report of bullying. You know, we don't need a definition of bullying. If somebody perceives themselves as being bullied, that's their perception and that's their reality. Other people may not perceive it as bullying, but you can't take away the person's perception. You might want to, with some people, I have gently tried to get them to think about trauma, no, not necessarily trauma, but bullying, about how they may have misinterpreted, but usually it's not a misinterpretation, it's an accurate reflection of what's gone on.
A lot of comments about EMDR. It's amazing, removes the pain, but leaves the memory. EMDR seemed very woo-woo to me on the face of it too, but worked for me so well. A psychologist also said no one really knows why it works, but then her experience, it does. It really, really did help.
Yeah. If you look at it in terms of brain functioning, I can see now from a neuropsychology point of view how this sort of idea of symmetrical, you know, the eye movements, the body movements, the tapping, the whatever, that I can see how that could set up some reprogramming in the brain, that we're so far off from understanding how the brain works, that I think even if it, and I know it's been put up against placebos, so it isn't a placebo, clearly isn't, it goes way beyond the placebo effect, but if it works, it works. And as I say, I've got two of my colleagues in Axia who I trust completely, who are using it. And for some people, it's working extremely well. Not for everyone.
somebody sort of commenting on avoidance of stress, saying, yes, there are autistics that are in a relationship, but for me, impossible, not because I'm autistic, but because I'm traumatized, so not daring to move in with anybody.
Yeah. And I think there, you know, I don't want to go over current news events, but there's been some things recently, haven't there, around women being able to trust. And I'm aware when things like that happen, that can re-traumatize people. And also, if you didn't trust certain people beforehand, some of the news that we hear is going to make it even more difficult. So that's a long way to come back from being able to trust, isn't it? When your trust is gone.
Yeah.
Sorry, I can't be more helpful. I just want to acknowledge that's a really difficult place to be.
A few comments about community mental health teams often not trained in PTSD, so staff maybe don't have the understanding. Somebody agreeing with that, and then unfortunately trauma gets basically swept under the rug. Wish professionals would be trained better in this topic.
Yeah. And one of our topics for our away day is a discussion around autism, attachment and trauma. And it's interesting because it gets swept under the rug as an adult, but quite often when we get referrals around children who are clearly autistic, that people make assumptions about trauma that they've suffered and attachment difficulties that they've suffered, when I look at it, I'm thinking, I'm not sure I would call that trauma, but almost like then negating the autistic diagnosis. Then when you get the autistic diagnosis, it seems like the trauma goes away again. So I think, you know, these things are hard to understand, and they are hard to hold all these things in your head, and not everyone's as intelligent as the autistic person in front of them. And I think that's what a lot of professionals struggle with, that they're often faced with people who are more intelligent and more informed than they are, and they find that incredibly threatening. I'm not making excuses for that, but I think that's certainly, you know, every day that I do meet an autistic person, there's a high percentage of them who are far more clever than me. I've no worries about acknowledging that and accepting that, but then that's what I then have to work with that. So I think you need to feel pretty confident in yourself to be able to say, the person sitting opposite me who is asking for help is actually cleverer than me. And yeah, I think that's difficult. And I don't think we necessarily give professionals the support to be able to say, you know more than I do, because the expert model is the prevailing model where the professional is meant to be the experts, rather than acknowledging they have some expertise.
Mm-hmm. Somebody saying they had a CPTSD diagnosis in 2009 and still can't access support. They think we're being unreasonable by constantly requesting it.
Well, again, it's like, why bother to diagnose someone and then not offering them, you know, for some things there are some very clear interventions that we know work, and some clear interventions that we know don't work. So, for example, ADHD, and, you know, as an adult, we know that the medication for a lot of adults works superbly. I just don't understand why the intervention doesn't follow when it's quite clear. So I'm really sorry to hear that over 10 years later, that person hasn't got what they need and deserve.
Going back to talking about sort of comforts, I suppose somebody has said, I've stopped caring entirely about being discreet.
Okay, yep, fair enough. No, yeah, it's like any time I say anything, I think, oh, that's probably not necessarily the right thing to say. I know a lot of people who, particularly once they've got the diagnosis, that some of the families say, since you diagnosed them, Linda, they've become more autistic, when actually, no, they haven't. What they've done is, like, here I am, take me for who I am, and if you don't like it, sod off. And I think I think it's great when people. One of the things I'm missing about not having conferences is some of my old mates who are just so out there and really proud of who they are, and they don't give a monkeys if other people don't like that. But again, you've got to be very confident to do that. And I love it when I see that. So yeah, well done.
Yeah. So there's quite a long question here.
Okay.
I used to have a job that comprised lots of small tasks. However, I had the freedom and independence to plan my own work weeks in advance. My current job varies between long tasks and periods of short tasks, but I don't have any visibility or autonomy. So whilst I'm in periods of short tasks with little to no notice, I really struggle with stress. How would I know if this comes to the level of trauma or just extreme stress?
Well, I suppose if it comes to the level of trauma, I would expect much worse sleep disturbance than there probably already is. I would expect a more complex physiological reaction, maybe flashbacks that sort of become paralysing. But I suppose the first thing to do would be to talk with whoever that person is, whoever the manager is, to just ensure that if it isn't trauma at the moment, that it doesn't develop into that, or to talk to somebody who might be able to help them when they're in that moment. So I want to, stupid expression, but nip that one in the bud. So if it isn't trauma now, it might become trauma, and can that be prevented? Because clearly that person has articulated exactly what is the trigger, which is what we were talking about before, that so very specifically in that task, that this, yeah, I think that needs an urgent talk with whoever is managing that person.
Yeah. An interesting question. Would you say that autistic catatonia is the extreme form of freeze response, or is it something else? It appears that extreme stress is always, or does it appear that that extreme stress is always the trigger for catatonia?
I did do a presentation on catatonia, which should be up on the website. Perhaps we could do a link at the end. I think that's a very interesting observation. I think the freeze response would be more of an acute stress response. But I suppose if you keep doing that and it then moves into chronic, another major cause of catatonia is certain psychotropic medications. So it might be quite interesting to look at what does that psychotropic medication that it affects the brain, really. So medication that you might have for psychosis, for example, where you're changing brain chemistry, that it might be that those medications, how they're impacting on things like dopamine circuits in the brain and so on, that could be a really interesting research study looking at that. And stress, that's a very interesting research study. I think maybe Evie and Chloe, let's, when the away days been and gone and we have a journal club, could we put that down as a really interesting research question for us to look at, the links between catatonia and PTSD?
Yeah.
And maybe do some literature searches that we could then share on the website. So a very interesting question. I'm sorry, I'm not clever enough to answer that, but I've got people who can make me cleverer.
Somebody saying, I heard that if there's a history of trauma, one is more easily traumatized versus a person who has not experienced trauma. Anything to comment?
I want to say yes and no to that. So one woman I met, which to me, this was hugely traumatic, but she didn't realise that every day people didn't wake up in pain. She thought everyone everywhere woke up in pain. And clearly to me, that's a traumatic event, but this woman had actually not got used to it, of course not, but managed her life with that level of pain. Whereas I think sometimes if you've had a one-off pain situation, I've seen people go to absolute pieces. I'm talking about neurotypical people and autistic people. So I think maybe if you're used to trauma, that your threshold then becomes higher. And if you've never experienced trauma, maybe you have no ways, you're not equipped to deal with it at all. So I don't know whether it's yes or no. It could be either, it could be both. That's another very interesting question.
Somebody said, how can we help someone with PTSD whilst they're waiting for treatment?
Well, I think that the first thing is accepting that that's what they're experiencing, not trying to diminish it. It's difficult, isn't it? Because what you don't want to do is be, sometimes what can happen is if people are talking about their trauma a lot, that actually that can drive people away. Because sometimes friends and family feel that they've heard it all before, they've nothing left to say. The power of listening is incredible. So I think it's not about problem solving per se, I think it's about listening. But if maybe you're feeling that you can't listen because, let's be quite honest, you might be getting fed up with hearing the same story, or you're getting traumatized yourself by hearing the story, that maybe you have a very frank and open discussion about times when it's okay for you to listen. So I think it's about looking after yourself as well. You know that stupid expression, if you're in an aeroplane, put your own oxygen mask on before you put somebody else's on. So I think it's about, you've got to be robust, because if you listen to somebody who's been traumatized, it's challenging. So all of our therapists have to have supervision around their therapy. Most therapists have to have experienced their own therapy as well before they're considered able to offer therapy, because when you're hearing people's trauma with empathy, you have to maintain a distance, and that's very hard when you're emotionally involved with someone. So it's about trying to maintain that distance but listening with empathy, and that's a really skilled thing to do. So I would say look after yourself whilst you're looking after that person, and don't tell them it's all going to be all right and or stop thinking about it, you know, it'll all go away. I think just listening without thinking, what can I do to make this better? Because actually just listening is the most powerful thing you can do.
Somebody said, I don't know if it is trauma, but if I try and socialize with someone and they reject me, it affects me for a good week or so. I have physical symptoms from it, like dizziness and feeling sick. And then unfortunately I blame myself. And somebody had commented below, rejection sensitive dysphoria.
Okay. I suppose, again, you know, going back to what Luke said, we all, when we're rejected, we all feel that. It's horrible. I suppose what we're talking about here is, you know, a big response to being rejected a whole week, but maybe not being able to distract themselves from that rejection. I suppose it fits in with the second but last slide about, I don't know if this is a woman or whether it's a man, but maybe the fact that social situations were a major stressor for autistic people as compared to neurotypical people who might just brush it off and go, oh, that's their problem, and then just move on to the next social situation. So again, I'd say take care of yourself. The ruminate, you're probably going over and over that social situation. Why did they reject me? Could I have done something differently? And you know, that expression, it's not you, it's not me, it's you, you know, it's like, oh, whatever the way around it is. It's you, not you, it's me. I think for a lot of autistic people, I think it'd be about saying, actually, it's not me, it's you. And not internalizing it as always, the autistic person has done something wrong, in inverted commas.
Okay, somebody asking, does attachment theory actually fit for autistics? I can kind of relate to the disorganized attachment style because of trauma, but not because of autism. Should there be another category for autistic attachment?
Well, I think we'll take that into our discussion on Friday. That's a really interesting comment. There have been a couple of research articles that have looked at the use of the Coventry grid, which is something that had been developed around attachment. Somebody's also gone on to develop a demand avoidant profile, autism and attachment. It's actually really quite difficult to discern. On paper, it's quite difficult to discern the difference. And I think you can have both. You can be autistic and have had poor attachments. I think that has to be disentangled from your relationships with others might be somewhat different. That doesn't make them disordered, but different. So I think we need to look more at early attachment and having stable caregivers. That seems to be one of the most important things, even if the way that person is relating. So I had one little girl who her mum could only feed her if she sat at a 90-degree angle. If she looked in her child's face, the child would scream and couldn't eat. The minute her mum sat in a different way, so she wasn't making eye-to-eye contact and fed her child would eat. Now, you can imagine a social worker coming into that scenario thinking, eek, this doesn't look like good attachment, but actually for that family, it was very good. So I think it's again, a very complex, it's a complex concept, which is one of the reasons we're discussing it at our away day. And if anything useful comes out of that, I think Chloe and Evie, I'm thinking we maybe might want to put some things on the website that come from the away day that I could talk a bit about in a moment when people are wanting or not wanting that we might want to put some things on the website.
Yep.
Yeah. So incredibly complex questions being thrown at me. Again, highlighting the intellect and rigor of the people that come to the group.
Yeah. A couple of comments on talking about being more autistic after a diagnosis. Once you have the diagnosis, it's actually like confirmation for you having felt different, so you dare to camouflage less. Somebody's saying, my child actually started flapping within about a week of diagnosis, age 18, said that up to that point they'd been holding their arms in for all those years and thought that everyone had to.
Oh, that's very upsetting.
Yeah. Let's see.
I'm glad that the diagnosis enabled that person to be who they are.
Yeah. Somebody saying, as a late diagnosed autistic person, I think up until age 18, going through school was continuously traumatizing. I didn't know otherwise until adulthood and getting diagnosed and being able to shape my life in a way that meets my needs. And it's taken a while to work through the old trauma of undiagnosed life.
Yeah, I think that's, I'm not trying to belittle that, but that's an extremely common response that lots of people I meet, they go back over their whole life and wonder how it might have been if they'd have known they were autistic, or if other people had known they were autistic. There's quite a good book written, edited by Luke, called The 9 Degrees of Autism, which talks about stages of moving through getting a diagnosis. There's quite a lot of books written by people who've been diagnosed later in life. And I just love it when we get 18-month, 2-year-olds coming to Axia, because we're starting off on the right path immediately, in my opinion.
Mm-hmm.
But it's never too late. You know, we've diagnosed people in their 80s and it's made a significant difference to their life. So I would urge people please don't think it's too late, it's not going to make any difference. It may well do. Of course, some people can self-identify, and that's a very legitimate thing, that you don't necessarily need someone like me to give you a bit of paper. That if you self-identify and that makes sense to you, that's absolutely fine.
Oh, somebody just asking who wrote that book that you mentioned there.
I think it's edited by Luke Bearden. Chloe, can you later, can you go and look in the resource list that Bev and you have come up with and see who's written it?
Yeah.
Then following on from the sort of 90-degree, sitting at 90 degrees, somebody saying at one point I could only communicate with my daughter via text as face-to-face was too hard.
Yeah.
Somebody else, direct facial interaction to a child might be too invasive. For some autistics, indirect contact feels safe, whereas direct facial interaction is a threat.
Yeah, I think actually in a lot of animals that if you think about cats, when they try and avoid looking at each other because it is a threat. It's that gaze thing. I think for a lot of autistic people, making eye contact is painful, uncomfortable. Donna Williams talks about losing oneself, that if you're trying to hold on to somebody else when you're looking at them, you lose who you are. And that's a very frightening place to be. So I think whatever works for people. The texting, I've recommended that married couples I've worked with where communication is not at its best, that I've had them sitting in the same room texting each other because that works for them. And again, that might look somewhat strange to other people, but if it works, just go with it. Don't listen to what other people say. Certainly never say, look at me when I'm talking to you. Disaster. And if you think about that, that's often used with neurotypical children as quite a punishing thing, isn't it? You look at me while I'm talking to you, because somehow that's a sign of respect. So clearly when we have people come into Axia, we say, so any of you are maybe not been to us and are waiting, then if any of you don't want to make eye contact, that is not a problem at all. We've had people sitting on the floor with their coats over their head, people moving their chairs around. It really doesn't matter. It's an observation that we can make, and we will include that in the report. But we'd rather you did that and be yourself rather than pretend. So we always want you to be who you really are, unless that's too scary and you have to come in with a mask on and then let the mask drop later.
Yeah. Comment saying, I find it strange, but in an understandable way, that I like doing things online, but then have a week occasionally where I dwell on feeling lonely, and that's probably the only time I feel down about being autistic and wonder what would have been different if I could socialise better. Unrelated to PTSD, but thought I would share.
Yeah, I think that's really, I really like the fact that there's a lot of sharing going on. That sounds like trite, doesn't it? But it feels to me like there's a lot of people sharing their experiences, which is quite difficult to do virtually. So I'm quite impressed with how well this is going with being able to share, which of course when we were in the room, it was much easier to do.
Yeah.
Can't stand the fact I can't see anyone. Well, I can see you two, obviously, but I can't see anyone else. I can't stand that.
Somebody had asked, so how do you help autistics learn to unmask?
Right. I suppose, how do you do that? First of all, I think you've got to value them. And you've got to value what they're interested in. And you've got to... So I know some people say that neurotypical people mask as well. No, they don't. What neurotypical people do is they present a different front, a different image in different situations. So they should present a different image at work than if they're having a drink with somebody, for example. But they don't lose sight of who they are in that process. They are just adopting, they still remain who they are in their core, and they're just adopting a different outside persona. Whereas autistic people, they can lose themselves in that masking process. It has a toll on people's mental health. The awful statistics of masking and suicide rates that we've got, the research articles on that. So how do you teach that? I don't think you teach that. I think what you do is you try and believe in the autistic person that's there and try and enable them to be the best autistic person they can, not the worst neurotypical person. Does that make any sense? I can't tell because I can't tell the person who asked the question whether they're going, that was a fat lot of use or that was helpful. I don't know. So I don't think it's about teaching. Maybe you need to notice, or they're not being themselves here. What are they doing? Why are they acting like that? That maybe you could talk about that after and say, that wasn't you. What was going on there? Mm-hmm. Then maybe privately you could, you know, if they want to sit upside down on the settee, that you just accept that's the way they need to be sitting. And if they think you're accepting them, maybe they'll be more easily able to either not care about other people or build some resilience around that.
Mm-hmm. A comment saying, I was reading about a lot of cool neurodiverse stand-up comedians, for example, Joe Wells, who talks about his severely non-autistic brother.
Yeah, I like that. Yeah. Yeah. That's, yeah, there's a lot of alternative comedians who got brilliant ways of, I don't know if people have seen Rosie Jones, the comedian with cerebral palsy. She uses her cerebral palsy so cleverly with the way she delivers punchlines. There's a really good comedian with tic disorder who, again, it's absolutely hilarious and you're laughing with the person, not at them. So yeah, I like that. Severely non-autistic. I like that.
Yeah. Somebody saying, I agree, it's the trauma, constant discrimination and breach of rights that are the problem, not autism per se.
Yes.
Somebody else, being around other autistics who are unmasking, stimming, etc. It's very validated.
Yes. Nothing to add to that. Brilliant comments.
Mm-hmm. Yeah. So where are we? I think Tom Stoltman is a great example. He masked and didn't communicate. He has spoken a lot about being himself.
Great.
And that's the last one, unless anybody else has anything to add. Oh, that Tom was the world's strongest man. I think there was a little, I'm sure.
That's right.
I think he's Scottish, if I'm not mistaken.
He is Scottish.
So, yeah, I remember that one.
Yeah. He's a great bloke.
Yeah. Oh God, there's a few coming through now, it's jumping. Somebody saying, to me, it sometimes happens that I keep agreeing to something out of politeness, being cooperative or peer pressure. And then at home realise it's something actually I don't feel comfortable doing, but because I'm still trained to camouflage, I can't react in time and say no.
Yeah. I think some of the dialogue, it's better. Yeah, I mean, I think it's hard for anyone where somebody says, oh, would you like to do that? You go, yeah, that's very interesting. But inside you're thinking, I don't want to do that. And of course, autistic people are not brilliant at lying. So they would feel wrong in saying, oh, I don't feel very well today. That's why I can't go to this social event. I think it's often better to have the discussion before So I know that sometimes when we've helped people who are in work situations where it's not going brilliantly, that they are never going to go, when everyone goes out on a Friday night after work, they are never going to go. They are never going to go to the Christmas party or equivalent. And so it's almost like that is said out there before somebody asks them. Does that make sense? So it's like, please don't ask this person every Friday. Come on, you're going to enjoy yourself once you get there. Please accept that they aren't going to come. And it's not that they're being rude. It's actually not good for their mental health, or not something they're going to get any pleasure from whatsoever. So it can be sometimes helpful to have that chat with, you know, a friend who might say, I keep asking you to come and have a sleepover and you keep saying no, that maybe a separate discussion saying, I really enjoy your company, but I can only deal with it in limited amounts of time. I will never want to come over and stay with you. It's not because I don't like you. I like you a lot, but I can't deal with it. And if that's done separately from the invite, I think that can be helpful.
Can you have both autism and BPD?
I'm not a massive fan of BPD, and I've had arguments with colleagues who are massive fans of it. And also I've seen some of the support groups where people are getting a lot from that group. So again, I think I'm not an expert in personality disorder, and the categories of personality disorder have changed again. They do keep changing. I think if you asked lots of psychologists and psychiatrists, they'd say, yes, you can have both. My experience is that I've met many women who've come to Axia with a borderline personality disorder diagnosis, and we're not in the business of taking away people's diagnosis. That's not what we do. But that when we've said about autism, for that individual, the autism makes more sense to them. However, what I would say is, you know, beware of so-called experts like me. If it makes sense to you, then it makes sense. If it doesn't make sense, then reject it. So if you feel that having both diagnoses is helpful and gives you support systems and groups that are useful, then stay with it. Doesn't matter what I think. These things are all, you know, did somebody use the word subjective before? There is no test for any of these things. It's based on observation, self-report, early history. So I think you have to take what's right for you.
Talking about masking there, someone saying it's really difficult. I told my friend and got the typical responses when I tried to explain masking without offending her. She said, I think we're all a bit autistic. Told her, no, we're not, though I've accepted and decided to continue masking with her.
Well, I suppose everyone know, yeah, we're all a bit autistic. We all like routine. That's a total misunderstanding of being autistic. I think if that's the way you're able to manage that relationship, if that relationship is worth the effort you're putting into masking, that's fine. I'd be worried if you were doing that with everyone, but maybe you can do it in small doses. If this person's friendship is that important to you, I think, again, that's personal choice. But yeah, I can't stand that. We're all a bit autistic. No, we're not.
Yeah.
It's like that. We're all a bit pregnant. No, we're not.
Yeah. Yep. Going back to BPD, couldn't the manic depressive states of BPD actually be stress-related responses of fight, flight, and freeze?
Yep. I think they could well be. Yep. There's very little written, and I think Chloe and Evie, you'll back me up on this when you're doing some research around it. most of the research around the acute and chronic stress response has come from animal studies and studies in zoos, and very little around human beings per se, let alone autistic human beings. I think it's seen as a sort of almost like a primitive response, which of course the acute stress response is. It's a very primeval one, but actually I think it can be very helpful, for example, that when you're in a stress response, that the ways you can trick the brain into thinking you're not. So this sounds very simple, but I've seen it work, is if in a stress response, if you're carrying around a bottle of water with you, that if you start drinking when you're in that stress response, that can trick the brain, because when you're in the acute stress response, your ability to eat and drink, it shuts down. So if you can then trick the brain into thinking, well, I'm drinking water here, so I can't be as stressed. This is a very simplistic way of saying it, but I can't be as stressed as I thought I was. Actually, that can sometimes bring the stress response under the individual's control. So I would have a go, people, everyone carries water around nearly now, don't they, anyway? So if you're getting into whatever you want to call it, panic attack, stress response, if you start sipping on water, can you trick your brain into thinking, I can't be stressed because I'm drinking? I wouldn't advise eating because you might choke on that, but water, drink of, or some, squash or something like that, nothing too thick, but something like the consistency of water to trick your brain.
Comment saying, with regards to stimming in public versus masking on it, on BBC primetime TV, Chris Packham was shown doing what looked to me as stimming, and he was called weird for it. I don't think this helps, as it shows it's okay to call people who stim weird.
Yeah. Yeah. It does draw attention to people. If you do something, that's very different and very obvious, people are going to look. And I think that is fine if, you don't care about that. If there's a way, so I've known people who can not suppress it, but when they get home, they then have to stim for a great deal of time. It's almost like that motor movement builds up inside them. Then when they get home, they can release all of that. I think you have to find what works for you. It does not help saying Chris Packham's weird. I don't think Chris Packham will be bothered.
Yeah. Although as autistic kids, and I see in my kids us commenting on weird stims until we learn it's a release of energy.
So is it that children are thinking this is weird?
I think so, yeah. They followed that up with education is important. Very,
very, very important. And again, that pent up energy that you can get, any of us parents, when your child's of a certain age, which must have been so awful for people who were living in flats and couldn't go out. There's a point where you have to get the child out to do something. Mm-hmm. Otherwise, your flat's going to be trashed. So I think, again, this is not, lots of people pick their fingers, pick their nails, pick at spots. I'm not saying those are stimming behaviours necessarily, but people buy rocking chairs so they can rock backwards and forwards. So it's all right when you're sat in a rocking chair, but if you're doing it in an ordinary chair, suddenly it becomes an issue when it's exactly the same movement. The movements that you get when a child goes to a playground, sort of round and round, up and down, all of that stuff that stimulates what's called the vestibular system and some of the other systems in our ears and in our brain. It's just sometimes some of the abilities. I've certainly worked with autistic people where their ability to bounce backwards and forwards in front of my head, and people watching are going to think they're going to headbutt Linda in a minute, and they don't, because they got it down to such a fine art that they just get close to your head and then they're back again and then they bounce forward again. I don't know why we have to get worried about that. I don't know why. Certainly rocking, back in the 80s, people were trying to stop autistic people from rocking by putting their hands on their shoulders and saying, stop rocking. I don't get why that's such an issue. If you go to a gig or a nightclub, I wouldn't want to say, stop moving about, stand and listen to the band. No.
Yeah.
We get caught up on the most stupid things that are of no consequence.
Yeah. Somebody else saying, I work in the NHS as a clinical specialist and find it strange how few of my colleagues know anything about autism, but we know so much about every other condition. It's also one of the few places where no one knows what the sunflower lanyard is, even though it's hospital. Apparently, autism mandatory training coming in the next year.
Yeah, I think it's really, well, that's really bad about the lanyard. Really bad. I don't know what it is about the training around autism. I keep hoping it's going to get better, but then I hear things like that and think, because it's so prevalent now, people can't run away from it. I think most people are getting their education from like Paddy McGuinness. It's like, apparently Carol Vorderman was on this morning talking about her son who's neurodiverse. So I think we're getting more from living celebrities than we are from academia. I don't know why. I really genuinely don't know why. And I know when I started in Sheffield for the clinical psychology training, there was hardly anything. And I just didn't get that, because autistic people are going to turn up in every speciality that clinical psychology trainees turn up in. You know, older adults, mental health, children, the lot. So I'm sorry to hear that's still the case.
Going back to stimming, somebody calling it, I quite like this sort of description, I suppose, a cultural cage for not being able to stim or not feeling able to stim.
Yeah. Yeah. And it is the context, isn't it? You know, somebody might, in certain scenarios, if you go to a gym, you'll see people engaging in quite repetitive, I'm not a gym person myself, but there's a lot of repetitive behaviours that go on there that people love. It's in that context. I like that cultural cage. That's brilliant. We'll have to pinch that one as well.
I've written it down.
Oh, yeah, we'll pinch that. We'll say it with someone from the group.
That's us all up to date with the comments again.
Okay. So we've only got, I realised didn't put, it's my fault, I didn't ask for the reference list. So if people want to read the actual articles on the website, the reference list will be there, won't it? As one of the slides. Yeah, so you can read it yourself. Just briefly then to say to people that we are having an away day on Friday. It does mean that there will be no one there to answer any queries and so on, but you can leave messages. But also we have been conscious that, you know, it's a difficult time, it remains a difficult time, that although we're not an out of hours or a crisis service, that we do want to alert people to all of the services that are, many of them still functioning, many of them still good. And some of you may know that often at Christmas time, Sheena Mansell, you'll see on the Meet the Team page, would produce something for us over the fact that Axia was closed for the holidays and where to go. But we've decided that that needs to be there all the time. So I don't know if Dream is there and whether he could say where the link is on the website to that resource, or whether we could just post it as part of today's session.
Hello?
Hello, Dream. Here he is.
Yes. On the website, if you go to the main page, if you click any link, on the right-hand side, there is the sidebar. And if you just scroll down the page a few inches and you'll see it there. There's like a where to go for emergency help or something. I can't remember the exact wording, but it's just like a little signpost that says, you know, click here, that takes you to the page straight away. So it's also in the menu bar under the links menu of emergency contacts or something like that, or where to go for help.
Yeah, thank you, Dream. It's very helpful. So the other thing we're going to do is on our telephone system at the moment, there's just like, if you want to leave a message, we're also going to have an option. You don't have to listen to the whole blooming option. You either leave a message, or if you're seeking out of hours mental health support, there will be quite a long message for you to listen to. So we don't want people to feel that there is nobody out there who cares. There are some people still out there who do care.
Mm-hmm.
So we're having the away day. I think there may well be things that come from that we will then want to put on our website, Facebook and so on. We are going to be discussing attachment trauma. We're also going to be focusing on when people don't get a diagnosis, and that can be a traumatic experience and needs to be handled very, very carefully. So we want to make sure that we're spot on with that, and that we're all aware of the impact of coming to us and then getting an assessment but no diagnosis at the end of it, or your existing diagnoses do explain all of it. So again, another complex area. And we're going to also be talking about things like an induction pack that Chloe and Evie have developed with some other people, that I think might be something that we want to put on the website as well, to give people an introduction to who we are. But I don't want to preempt what's going to happen on Friday. So we're not going to be around on Friday, but we're all going to be in Chester. We don't do this very often, so bear with us. There won't be anyone to answer the phone. Is there anything else, Chloe or Evie, that you feel?
I'm just going to mention that on this away day, we are also going to be having discussions about the future of the post-diagnostic support group, and whether, you know, with restrictions changing and things, how accessible it's going to be to do more face-to-face, and then how we can accommodate for people that would still prefer it virtually. So we are considering all options and trying to come up with the best solution. So we should hopefully get back to you with more of an idea after this away day on Friday. Yeah,
we're also, you know, open room has been suspended as well. And again, we're preparing for a reopening of that in some way or other, but we want to get it right for people. So yeah, if you could bear with us, we've got a lot to talk about on Friday. And just keep in touch with us. Subscribe for the monthly roundup. Keep looking at the website. Post comments, guest reviews, anything. Just stay connected with us.
Mm-hmm.
Thank you.
Okay. So I think that sort of wraps it up for today. The next session will be next month. Off the top of my head, it's 17th. There'll be posts as usual coming up on the website closer to the time with more information and what it will be about. But yeah, 17th is the date we're working with. So yeah, thank you everyone. There was great discussion, loads of comments. I've got another laptop here saying 99 plus comments, so that's wow. Great. Good discussion. So yeah, thanks everyone for attending. We'll hopefully see some of you next time.
Hope so.
And thanks, Linda, as well, for joining us.
That's a pleasure. Always a privilege.
Okay, well, hopefully see you all next time.
Thank you.
There'll be more information soon. Bye-bye.
Take care, everyone.
Bye-bye. Bye-bye.